Welcome back. This is part 2 from the Systemic Lupus Erythematosus lecture by Abdulazim Al-Hifni, Professor of Internal Medicine, Rheumatology and Immunology at Shams University. In part 1, we finished lupus definition and epidemiology, and we focused on the classification criteria, the old and the newer one. In this part, we will proceed to the rest of the lecture. This is the ILOs of the lecture if you want to revise lecture. The clinical criteria: acute cutaneous lupus. This is an erythematous and edematous eruptions present in the malar rash, malar area, and sparing the nasolabial fold bilaterally. This is characteristic, and also it can occur in the abdomen, in the trunk, and the lesions have abrupt onset and frequently appears after exposure to the sun with erythema and edema. Malar butterfly rash: fixed erythema, flat or raised over the malar eminence, as we see. Distribution over the cheek and bridge of the nose, sparing the nasolabial fold, as we said before. The differential diagnosis is sunburn and chloasma, but these cases did not spare the nasolabial fold. The rash may precede or accompany other manifestations. The involved skin feels warm and edematous, and the rash may last for hours or days and often recurs, particularly when sun exposure occurs due to ultraviolet radiation. Subacute cutaneous lupus: it is non-itchy dry rash, appears on the upper back and chest, often following sun exposure also. It is erythematous, slightly scaly, and has annular or polycystic pattern like we see here, like that. Number 2, chronic cutaneous lupus in the form of discoid rash. It is erythematous, raised patches like we see here and here, raised patches, and erythematous with adherent keratotic scaling and atrophic scarring like here and here, may occur in the face or in any part of the skin. Photosensitivity: it is common in the lupus patients. The development of skin rash as a result of unusual reaction to ultraviolet B radiation found in sunlight or fluorescent lights also. It occurs in 60 to 100% of cases. The incidence is also greater in those with anti-Rho antibodies. Number 3 of the clinical criteria: oral and nasal ulcers, like we see here. The oral or nasopharyngeal ulcers usually painless and observed by the patient or physician. It is unlike that present in Behçet disease, which there it is very painful. Here it is painless. Number 4 from the clinical criteria is non-scarring alopecia, either localized or widespread alopecia without scars. Also, Raynaud's phenomena and vasculitis may occur in SLE patient, but it is not criteria of the disease. Number 5 from the clinical criteria is arthritis. Arthritis in SLE is non-erosive and non-deforming, unlike that in rheumatoid arthritis patients, involving two or more peripheral joints and characterized by tenderness, swelling, or effusion. Deforming features such as ulnar deviation, hyperflexion, or hyperextension are generally reducible. It is not fixed deformities like that in rheumatoid arthritis, but it is different. There are secondary These are secondary to involvement of joint capsule, ligaments, or tendons, and not due to erosions or destruction of the cartilage or bone, and are referred to as Charcot arthropathy. These are arthritis, swelling, causing swelling of the proximal interphalangeal joints and metacarpophalangeal, like the distribution of rheumatoid arthritis, and this is deformity, apparently deformity like that in rheumatoid arthritis. This is swan neck, but when we did X-ray, there is no destruction, and it is due to involvement of the joint capsule, ligaments, and tendons. This is the Charcot arthropathy in lupus patients. And this is the difference between lupus arthritis and rheumatoid arthritis. The most important thing here is subcutaneous nodules are present in about 35% in rheumatoid arthritis patient, and the erosions are common. The morning stiffness is hours in rheumatoid arthritis is prolonged, and the swan neck deformity and ulnar deviation deformity are common in rheumatoid arthritis as in lupus patients. This is the end of the second part, and we will meet soon in the third part of SLE lecture, and thank you.